Hello, everyone. Welcome to our June webinar for CalMAP, California Child and Adolescent Mental Health Access Program. For our session today, our topic is nuanced autism patients with age-level cognition and language. For those who don't know me, I'm Eileen Ho-Hui-Wang. I'm one of the child psychiatrists at CalMAP. I staff the consult line and also help organize educational activities along with our CME committees. For those who haven't heard of us, we're called CalMAP, previously CAP. Please call us at 800-253-2103 for a consult, or you can request a consult online once you once you have an ID. We provide real-time consultation that includes clinical and personalized guidance on how to apply what's taught in our webinars, including our webinar today, to your own patient's care. So give us a call or request for a consult online if you have any clinical questions after today's webinar. Marcus, if you could pull up the slides, I think there are a little bit more information about how PCP can request for consults. And this year, we also have a new program. We have an on-demand webinar, and this monthly webinar series recordings is available for you to watch on your own free time, and you can answer a CME question afterwards to get CME credit. If you get a passing score, which is 66% or higher, then you will be eligible for 1 hour of CME and 1 hour of American Board of Pediatric MOC Part 2 credit for each webinar you completed in this way. The other housekeeping item is at the end of today's webinar, please make sure that you either click the link in chat or use the QR code that's displayed at the end of the webinar to claim your CME credit. And since this is the only way to get the CME credits now, it's really important that you remember to do so. If you have any questions during the talk, please feel free to use the Q&A feature on the bottom, and we'll make sure to reserve 15 minutes to answer your questions live today. We're going to begin introducing our speakers today. It's our pleasure to have Dr. Enjey. Dr. Christy Enjey, PhD, BCBA, is a clinical psychologist and associate clinical professor at the Center for Autism and NDDs in UCSF. She has special training in behavioral analysis and is a board-certified behavior analyst doctoral level, BCBA-D. Her specialty area is in the evaluation and treatment of youth with autism and related neurodevelopmental conditions. Her clinical and research interests are in applying and developing evidence-based treatment for youth with autism to treat core symptoms area and co-occurring anxiety. Her treatment approaches are cognitive behavioral therapy, CBT, and behavior therapy. She completed her clinical psychology doctorate degree at UC Santa Barbara, internship at the Lucille Packard Children's Hospital at Stanford, and a postdoctoral fellowship at UCLA. Prior to her work at UCSF, she was clinical faculty at the UCLA Child and Adult Neurodevelopmental Clinic. We also have Dr. Cory Patrick today. Dr. Patrick is a child and adolescent psychiatrist in the Division of Child and Adolescent Psychiatry in UCSF. He primarily provides outpatient psychiatric care through the UCSF Center for Autism and NDDs, where he sees children and adolescents, as well as adults with autism and other neurodevelopmental disorders. He also at times provides psychiatric consultation through the CalMAP portal. Dr. Patrick completed his bachelor's degree at Rutgers University, medical school at University of Miami, residency training at WashU St. Louis, and child and adolescent psychiatry fellowship here at UCSF. He completed a master's degree in genomic medicine alongside his MD at the University of Miami, and continues to have interest in treating individuals with neurodevelopmental disorders related to rare genetic disorders. I'm going to turn it over to Dr. Patrick and Dr. Lin.
All right. Great. Yeah. Thank you so much for the introduction, Eileen, and thank you all for coming here today to see our presentation. And yeah, so today is our kind of second talk this year about autism spectrum disorder. And we are going to be focusing a bit more today on a specific subpopulation, individuals with autism who have age-level cognitive and language skills. A few learning objectives for today are, we hope to identify, 3 ways to mitigate challenges in evaluating and treating psychiatric conditions in individuals with ASD. We'd also want to help support you identify first-line medications for treating common psychiatric conditions. And then Dr. Lin will focus on teaching you all about elements of evidence-based therapies for youth with autism. Next slide. And so the scope of today's presentation, so we'll be focusing on this specific subpopulation of individuals diagnosed with ASD, but I also want to, and some other kind of ways this group may be referred to are individuals with ASD level 1, individuals with ASD without intellectual impairment and without language impairment, or kind of older DSM-4 categories of Asperger's syndrome or high-functioning autism, which are still used sometimes. And also kind of recognizing the reality that for many individuals who we may suspect of having autism, especially people who are presenting later, or who we at least think there's a high degree of autistic trait burden. There's a gap between when we suspect these problems may be present, and when we can get a full evaluation or confirm a diagnosis. So we'll be aiming to provide you all with a little bit of a framework that you can use in those cases as well. All right, and the other kind of group that I wanted to just point out early on is that, especially for individuals presenting later in life who have age-level skills, if you're just meeting them, you may not be fully privy to or haven't seen them go through earlier struggles where there were some sort of delays and necessity for catch-up. And it's always important for those patients to kind of keep in mind that delays may have been part of their history and part of their own personal narrative that still has an impact on them. Next slide. All right, so first, let's talk a little bit about kind of identifying this group of individuals. So when it comes to ASD diagnoses, we know that there are a few factors that are correlated with earlier diagnoses, including lower cognitive functioning, lower language ability, higher level of parental concern, as well as male sex. So kind of the population we're talking about today is particularly at risk for later diagnosis, and this is reflected in the kind of most recent CDC data that was published looking at data from 2022 following individuals who are 4 and 8 years old. And looking at the 8-year-olds, there's a kind of 6-month gap in average diagnosis time for those with and without ID. And likely that's an underestimation because people who are kind of being diagnosed later in life on the tail end are often falling into the category of the group of individuals that we're talking about today who are of age-level abilities. There's a good paper out of the UK that kind of summarizes some of the possible reasons that these individuals are being caught later. Some possible contributing factors include, them not having the same developmental red flags that are leading to intensive evaluations earlier in life, potentially having milder ASD symptoms overall, placing them more around the cutoff, though in this particular research, they identified that a lot of these people, in hindsight, parents are reporting a lot of like this similar amounts of symptoms early on when they're investigated thoroughly. Or the cognitive abilities and language abilities are allowing these kids to kind of mask or camouflage more. And then another idea was that there may be some diagnostic overshadowing going on, though when this was investigated, particularly with ADHD, there wasn't clear evidence that this was happening, at least in one particular study. Next slide. So just to kind of review for everyone. So for this group of individuals with age level abilities, the DSM criteria, and to meet a diagnosis for ASD remains the same, though individual signs and symptoms may present a little bit differently. So as a reminder, sort of for our social communication and interaction deficits, we need to have signs and symptoms in all three categories. For restricted and repetitive behaviors, we just need to have symptoms in 2 out of 4 of those categories, and these symptoms need to be impairing for the individual. And on this slide, I'm not going to go over everything on here, but I included some examples of symptoms within each category that may be a little bit more easily missed, but maybe kind of presenting in some of the patients that you're seeing who have age level cognitive and language abilities, or are maybe not diagnosed, but you're suspecting ASD. So for example, in terms of deficits in social emotional reciprocity, they're a subset of our kids who have really good initiation, who are pretty verbose, but they really struggle when it comes to like maintaining or continuing a conversation. So kind of in briefer interactions that are, focused on the patient, it may be missed that these social deficits are occurring, but they may be things that are brought to you by teachers when or peers or parents kind of later on as social expectations become more complex. And then on the restricted repetitive behavior side, under the rigidity and insistence on sameness category, I have kind of kids with good behavior, what some people may perceive as good or desired behavior being missed. So for example, kids who are very routine oriented, but those routines kind of fit into their parents' schedule or are perceived as kind of not interruptive, but they may become problematic if there's a confrontation to that routine, or there's some change that's occurring. Or in the school setting, perhaps kids that are really rule bound and very strict with adhering to rules may be seen as like model students by teachers, but this may also potentially cause challenges with peers and also fit into that category of rigidity. Next slide. And so if you do kind of suspect autism in a child who's older and hasn't been diagnosed yet, I think here's a few kind of brief steps on things that you can do to move towards evaluating that further. So I think it's always helpful to gather further collateral, and that may involve using scales, which can be a really efficient way to ask a lot of questions and get a lot of information. I prefer the social responsiveness scale, which can be given to teachers and parents, and older teens, you may find it appropriate to use like the adult self-report scale, at least for information gathering purposes. And also pulling on like IEP documentation that may exist, or for school-based people, setting up a call to get some medical collateral. I think another thing that's really important is when there is some sort of concern that's arising, even if it's just a suspicion, making sure that you document that to kind of create a trail of concern for other providers. People switch providers a lot, and sometimes these suspicions may get lost along the way, but it's helpful to know that other people had noticed these things along the way, as oftentimes are differential with ASD versus other conditions. Sometimes how we determine one versus the other is based on whether symptoms are persistent or kind of episodic in nature. And then a third really important one is to explore your suspicions with the patient or the parent. And this, may help to reveal any prior concerns that the parents had that may have gone unaddressed, or, give you the opportunity to address any misconceptions that the families have around what autism is. And I think particularly with this population, I think education around the autism diagnosis has increased a lot, but there are still a subset of people out there who, have a specific picture of kind of individuals who have delays or intellectual disability, and kind of associate ASD with how ASD symptoms present in those populations and may kind of preclude the possibility in their own child if they're not meeting those expectations. And then I think the last thing is, of course, to initiate a formal evaluation. And I know Marielle, our social worker, went over that in the initial presentation, and we have a really good resource guide online on how to go about initiating evaluations for kids with ASD. And you can always use our care coordination consult line to get further support for individual cases. All right, next slide. All right, so now we'll move on to talking about kind of addressing some common social emotional challenges in individuals with ASD. Next slide. So as a lot of you probably know, individuals with ASD have very high rates of psychiatric comorbidity. Around 70% are estimated to have another psychiatric condition. And really the increased rates go across the board, but especially in ADHD and anxiety. And in the population we're discussing today, individuals with higher IQ have even higher rates of anxiety, though they some studies have also shown that they have relatively lower rates of aggression compared to other kids with ASD. And then it's also important to keep in mind that there's a bidirectional relationship between these other diagnoses and symptom severity and ASD symptom severity. Not pictured here, there's also higher rates of kind of gender dysphoria and gender incongruence in individuals with ASD. And then beyond just psychiatric conditions that are formally diagnosed, kids with ASD also have, increased challenges, increased rates of bullying and other school-related and social challenges that are really important and may come in as the presenting problem when they come to your office. Next slide. Yeah, and so diagnosis of psychiatric comorbidities can be really tricky in individuals with ASD. And there's a lot of overlap between the signs and symptoms of ASD and most other psychiatric disorders. And kind of, a few examples on the slides, but for example, like kind of flat affect or flat vocal tone can be a symptom of depression, but also ASD. And oftentimes, like with these symptom overlaps, kind of asking more detailed questions can get us helpful information. If we have, the time to be able to go into a lot of detail. But sometimes even with really good detailed questioning, you're still in a position where it's not entirely clear or you're convinced that both are going on. And I think another kind of factor often present in kids with ASD that can kind of make diagnosing other conditions difficult is alexithymia. A lot of kids with ASD struggle with emotion identification and verbalizing those emotions, which of course can sometimes make it challenging to meet certain kind of symptom-based criteria. And kind of the third group of challenges that I want to point out is, even though kids may have age level cognitive and language functioning, they often have lower adaptive functioning compared to their peers. And this is sometimes forces the clinician to kind of adapt, and that can be challenging. As we know, like most of our psychiatric conditions require some kind of like decline in functioning or related to the symptoms, and it's important to kind of understand the patient's baseline in order to be able to assess that decline in functioning. All right, next slide. Yeah, or go back one slide. Yeah, and a few strategies to kind of manage these challenges. So I think one really important one that kind of cuts across these challenges is to make sure to incorporate collateral sources as much as possible. And that can be parents, schools, and that's especially important with things like alexithymia, where you're you know, the child themselves is not able to tell you about their symptoms. It can also be helpful to incorporate the parents in the interview so they can help the child use their own language a little bit more effectively, or identify shared language. And then I think using scales to provide opportunities to give multiple different means and mediums to report symptoms can also be helpful. Next slide. Right, and so the next kind of helpful step in treating individuals is to formulate a case conceptualization. So often in psychiatry, we use the biopsychosocial model depicted on the left, and I broke that down a little bit more on the right. So I think one helpful question to ask yourself is the presenting problem driven by symptoms of autism spectrum disorder? Is it driven by a comorbid psychiatric condition, or is it clearly a combination of both? And that can give you a good jumping off point to design your treatment approach. Next slide. On this slide, I have, so I think the next step, if you do think ASD symptoms are playing a role, that can be helpful. And this is relevant even for individuals who don't have a formal diagnosis, is to really think about which category of symptoms is contributing to the problem at hand. So for example, one presenting problem may be a child is coming home after school really burnt out and they're unable to engage in their activities. And then you may learn that it's, you know, they're reporting it's due to a lot of sensory overload during the day that's preventing them from kind of engaging and exhausting them. So you may work on the family to support providing like sensory relief during the day. And then Enjey is going to talk about in more detail some other strategies around particular symptoms and how to incorporate that into CBT and ABA therapies. Move on to the next slide. Medications are also often appropriate, especially when there's a psychiatric comorbidity present. Before kind of considering a medication, we always want to make sure to revisit our case formulation and optimize non-pharmacologic treatments. And we also want to check in with the case and determine if a higher level of care may be necessary. As well, fortunately for this particular population, there are often like IOPs, PHPs who may be accepting of individuals with ASD who have age level abilities, which isn't always the case for other people with ASD. Next slide. In terms of choosing specific medications, I think there's broadly a dearth of specific studies looking at medication management in individuals with ASD. So a lot of our kind of treatment algorithms with medications are based on the neurotypical population, and kind of your first line medication choices are going to be the same. And we can go into a little more specifics for our common conditions. Next slide. So for management of ADHD, first line treatment will be stimulants, and methylphenidates have been studied a lot more commonly than amphetamines in individuals with ASD and are shown to have strong benefit, maybe slightly less than in neurotypical populations, but still they can certainly make a big impact. And then other agents that can be helpful to think about are alpha agonists. The appetite suppression and weight loss side effect is often a problem with stimulants with kind of all populations, but especially if you have kind of picky eaters in ASD. And then atomoxetine is also another option to consider. Next slide. For anxiety, depression, and OCD, SSRIs remain first line. When using SSRIs in this population, kind of activation is one of the primary things we're worrying about. And I'm always especially wary of the activation side effect in individuals where there's already aggression going on. That being said, SSRIs can have a very great impact and can also be helpful for aggressive behaviors and severe emotion regulation issues when they're driven by these other conditions. And with SSRIs, it's kind of a general framework to follow is to start low and go slow. But I think it's also equally important to keep in mind not to to underdose people. All right, next slide. And then for insomnia, melatonin is very well studied in individuals with ASD and can be helpful for sleep initiation. It's not quite as helpful there's not good evidence showing that medications are really helpful for early morning awakening, which is a problem parents with kids with ASD will often bring to you. And for this, I usually recommended kind of taking a behavioral approach and working with therapists on. Next slide. And then kind of the last group of medications and indication to talk about today is the treatment of irritability and aggression in individuals with ASD, which is a unique indication in this population. So you mentioned before how individuals with age-level cognitive and language skills have kind of lower rates of this, but definitely can still be relevant for this population as well, especially when they're younger. And before starting antipsychotics, Abilify and risperidone are approved for this indication. We definitely want to think about optimizing non-pharmacological interventions as well as pharm treatments for other psychiatric comorbidities. And then we would want to adhere to the following principles, including minimizing dose exposure, making sure we adhere to monitoring guidelines for weight, as well as lab draws. And then considering metformin if we're doing long-term use of antipsychotics. Yeah, and similar to SSRIs, we would want to kind of start low doses and kind of go up gradually as needed. All right, next slide. And then before I hand it over to Enjey, just want to quickly review kind of some of the resources that we have present online. So you can always kind of call in for live consults, or if you've made a consult, do a follow-up e-consult, or and then you can check our website for medication guides on starting SSRIs or using ADHD medications, and then how to get services guide, which is quite thorough and helpful. All right, I'll turn it over to Enjey.
Okay, great. Thank you. Can you hear me okay? Awesome. All right. So thanks, Cory, for setting it all, the context all up. I'm going to be talking about non-pharmacological treatment. And really the point for me is making sure that you guys have information to help guide your patients in their selection of treatments for this population. So something unique for ASD that's probably different for for kids with other kinds of mental health conditions is that there are these two kind of sets of areas that you need to think about for children with autism. One is that you are thinking about like their core characteristics or symptoms that they need help with, that, changes in terms of like what's needed as they grow over time. But then for a large portion of them, it's also thinking about their mental health and what they need to help support them with their wellness. And so it can feel overwhelming at times because they both need attention, and different aspects of their autism symptoms or mental health fluctuate and may become more necessary to treat than other areas. Next slide. One of the things that all the research does show is that there is a universal helpful therapy approach to supporting youth with autism. And really the elements that seem to be most helpful are explicit teaching, active practice of skills. And what I mean by this is like, giving kids tools, modeling it for them, and then having them practice it both in session as well as with their families outside of session. And you're really trying to grow these adaptive behaviors and helping them to adapt and be as successful as they can in their environments. The type of treatment approaches that really have these elements are behavioral approaches. One is behavioral therapy, and the other is applied behavioral analysis. They're both quite similar, which is what I'm going to be talking about, but there's nuances to them. It's not to say that other types of treatments are not helpful, like talk therapy or traditional maybe play therapy. It's just that this type of treatment approach has the most maybe immediate impact that you could see, and has observable things that you could see in terms of changes of adaptive behavior. And so you really want to grow those adaptive behaviors. Next slide. this is going to be a helpful way to think about what's the difference between behavioral therapy and applied behavior analysis. And behavioral therapy are things that you and I all have probably done, especially if you have children, things like parent management training or PCIT, which is parent-child interaction therapy, or things that maybe our own therapists or coaches have done with us. And then there's applied behavioral analysis, or ABA, that many of us have heard of, but I want to share how they're similar and not similar. Behaviorism is the approach. It's a way of looking at how people learn from their environments and from each other. And both behavioral therapy and ABA fall into the science of behaviorism. Behavioral therapy is a little bit broader. You are tracking broader changes to behaviors. It's a bit of a broader approach, whereas applied behavior analysis, again, it's the same idea. They both kind of focus on behaviors. How do we change behaviors? Behaviors are actively taught in practice, and behaviors are influenced by the outcomes of what somebody does, as well as associations, what's going on around them. Applied behavior analysis takes a step further from what behavioral therapy provides, and that it's more systematic. There's a detailed examination of, if I did X, what's the impact of X on this person? And also identifying crucial components of, hey, what was the most, what was the thing that really kind of associated with this change in behavior? And it's really looking for personalized ways to look at treatment or strategies that were done, and looking through data, what happened. And so it's very similar to what you see in behavioral therapy in terms of the types of things taught. It's just that it goes an extra level of really looking finely and at very detailed ways, what's the impact of the intervention that I did, which elements are the most effective, and it's a lot of gathering of observation and data to make sure that the treatments and interventions you use are really personalized and effective for the child. Next slide. I'm going to help hopefully broaden your perspective of what ABA is, because I think there's a lot of misunderstandings in our communities about what ABA does or doesn't do. And ABA, as I said, is under the umbrella of behaviorism. So it's a science. It's the science of learning, but it's really focused on teaching and examining adaptive behaviors. By adaptive, I mean behaviors that are most helpful to somebody to be successful in their environments. ABA is used with people and animals. It's used in lots of different settings, schools, homes, and businesses, and it's used across the ages. It is not just for problem behaviors. It's for figuring out what is important in this community or in this group, and how do we help change behaviors to get towards that goal. It's for all people. It's for people who are in the general population. It's used in hospitals to help doctors have better skills with different kinds of intervention that they need to do, like hand washing and different things. But it's also used for kids who have autism, intellectual disability, and other kinds of developmental delays and genetic conditions. So I hope that this helps a little bit to help expand the understanding of what ABA is, who does it apply to. Next slide. For us, in terms of working with kids with autism, something that could help, especially for those of you who have kids, well, there's, you have kids who are more impaired, who have less language, and then you have kids who do have more language and who have more abilities. Something that might not be as familiar to a lot of people is that there are actually two broad approaches to ABA in terms of interventions for autism. And these two types of interventions, they're not just meant for autism, they're meant for kids with all types of intellectual or developmental delays. We'll talk a little bit about why is it that we all think that ABA is only for autism. But I just want to keep you guys, keep it in mind that's for all kids with developmental delays. But there are two types. One is called discrete trial training, which has the oldest history, that was developed as the first line of first treatments for kids who had intellectual disability and autism. And these were the first set of kids who were diagnosed. There were no interventions around. They were older and they were very impaired. Then you have, after that, an offshoot, or the other part, the more contemporary part, which are what are called naturalistic developmental behavior interventions, or shorthand would be NDBIs. These are more recent, and I say more recent because they're kind of like in the late 70s and 80s that were developed. And they're just, they are growing in terms of being offered in the community, but it's just a slower uptake in community providers because discrete trial was created first. The three major types of NDBIs are Project Impact, Pivotal Response Treatment, and Early Start Denver model. And they have different age ranges that apply to, but NDBIs as a total, and discrete trial, those elements, they are applicable to kids who have neurodevelopmental differences across all ages. So it's a misunderstanding that really some of these are only for young kids. They have application to kids and people of all ages. There's two, Project Impact and Early Start Denver model, that does have kind of this age limit. But PRT, and like I said, just the overall model of using a naturalistic intervention is meant for people of all ages. And so you might want to guide your families, especially for those maybe who have more language, more social interests, guiding families to ask for a naturalistic developmental behavior intervention when families are seeking them out from the different behavior agencies that they're going to work with. Next slide. So I'm going to give you an example of how discrete trial and a naturalistic intervention might work. Let's say I'm working with a kid and I'm trying to get them to use the word or learn the word nose. If I did discrete trial, it's very structured. Remember, it was made for people and kids who are very, very delayed. And so the learning was meant to be where the learning goal was very salient and you were decreasing as many distractions as you could. So discrete trial often happens at a table. You sit across from a kid and the therapist might hold up a flashcard or a picture of a nose and have the child say nose. And when the child does, they might tickle them or give them a Cheerio or a sticker to help reward them that they said nose. They might do this for up to 10 trials because you're trying to really kind of establish that learning. For naturalistic intervention, if I'm teaching the child the word nose, I'm going to be thinking about what are the things that they're motivated for and what are the natural activities that they enjoy or do each day. The idea is that if we teach a natural context of activities, motivating activities, kids might need fewer trials of learning, and those learning outcomes will be more salient and meaningful, and it'll stick with them easier because you're actually using them in the settings and activities that they need it in. And so if I know that a kid really likes to go to the playground, I might have the child say nose. As soon as they say nose, I put sunblock on their nose, right? Very naturalistic. A natural outcome is putting, sunblock on the nose after you say it and then going to the playground to play. So you could kind of see this difference. You're going to have less trials with naturalistic interventions, but it's really tied to the activities a child does and what they're motivated for. Next slide. For behavioral interventions, ABA-related interventions, there are lots of treatment goals. You can target reciprocal conversation, entering and joining social interactions. You can target developmentally appropriate play behaviors, such as a child playing on their own in appropriate ways, developmentally appropriate, so matching their mental age, and even playing with other people. You could teach adaptive skills to replace problem behaviors. So instead of hitting, teaching kids to say, I need space. And you could also teach daily living skills like personal care, like how can you help them to brush their teeth more independently? You can also use ABA to help them with their communication so they could be, have better social communication skills, learning how to make more comments, learning how to tell people about the experiences they had, sharing about their day. Next slide. The current reality and why we probably all have misunderstandings of what ABA is really the scope of ABA has been very limited by insurance. Insurance has dictated, hey, you can only have ABA if you have autism. And that's made people think, well, ABA is only for autism, but that's actually not the truth. That ABA really is made for, all kids with neurodevelopmental delays, but also ABA is used widely to address many different issues as well. There is also a high demand for ABA, so there's a shortage of the workforce that really impacts the quality and the age range that services can be provided. Another thing that comes into play is that the training for a lot of ABA providers is really poor quality, and that really has impacted many agencies really, having a lot of turnover and maybe even only focusing on certain age ranges. They might say, we only work with kids, and that again creates this misconception, ABA is only for kids and not for adults, but that's really not the truth. And then there's, an emphasis, there's a change, a shift in history now where it seems like there's a lot of center-based care that's being provided rather, or being offered versus in-home care. And really center-based care is how ABA was provided in the beginning. And there was a big push to have it in the homes because they were finding that, hey, when we have kids learning in a center, they're not transferring those skills into homes. And so really, we really want to have a balance of home and center-based care if center-based care is going to be used. But remember, there has to be some help to generalize skills in the settings they need it. The other thing to keep in mind is ABA is an evolving science, and there is negative history associated with the ABA. And I think that's similar to the negative history that, child, like parenting skills or just the ways that we address children's emotion regulation and emotional development was really lacking just because of the lack of science. And so there's a big move now to recognize the mistakes that were made in ABA, using physical punishment or maybe trying to continue to have kids follow through with certain instructions, even though they were having emotion dysregulation. And so there's kind of this new wave that's happening where it's called contemporary or compassionate ABA practices that's coming online, because there's a better understanding of the emotion and regulation needs of kids who have neurodevelopmental delays, and all kids. All right, next slide, and we're going to be wrapping up soon. As you guys heard from Cory, there's a really big need for mental health care for autism. There's, 30 kids who are neurodiverse are 30 times more likely than the general population to seek emergency care, especially for those with unmet mental health care needs. There's a lot of common conditions that Cory talked about: ADHD, anxiety, depression, and problem behaviors. Well, problem behaviors is a general umbrella term that we need to kind of look under and be like, well, what's driving those problem behaviors? Next slide. There is this big interplay that we need to think about, that when we are looking at mental health conditions in autism, you do really need to look at the features of autism because they are interconnected. And I think that's what makes it tricky in treating kids with autism, is that you kind of have to keep these two hats on and kind of think about, well, how does, anxiety, ADHD, or depression, how does it affect features of autism? And how am I seeing these symptoms of, anxiety or ADHD or depression in kids that map onto that of the general population? Next slide. So in order to, we talked about like what are the things necessary to help kids with autism. Definitely ABA is one of them, behaviorally based therapy is one of them, but so is cognitive behavioral therapy. And why? Ding, 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 the word behavior is in there, right? So CBT works on thoughts, actions, and feelings. They have both the cognitive piece and the behavioral components. What is CBT doing? Well, we're developing adaptive ways of thinking and behaving. So, new learning to really help kids. And we're doing it by having children be active partners in developing new adaptive or helpful experiences. And you're trying new behaviors and you're discussing what's happening. Next slide. And so underneath what CBT is doing is really we're creating new mental frameworks, right? We're helping them have these mental frameworks to help guide these more helpful responses. And there's a couple things that we want to think about and what you want to make sure parents are kind of assessing for and asking for. One is we want to help kids to retrieve these helpful memories. And to do that, you got to factor in, well, what's the setting that my kid's learning them? What's the mental effort required for my kid to pick up these skills to help them remember? And what's their mood like? A couple of things to keep in mind is that active learning really helps kids to practice the skills they need. And then if they are learning the skills in the situations they learn it, that helps them to pick up those memories and behaviors more. But the other part that's really important is kids really do need to have some pleasant experiences when they're learning these skills so that it's easier and faster to retrieve those memories and behaviors and skills. So that's something to keep in mind to check in with your patients when you're talking about how is CBT going for your family. Okay, next slide. So CBT for autism really needs to be modified or enhanced or adapted. So you're really modifying the treatment to meet the unique needs of autism because there are differences. There are differences in the ways kids with autism uptake skills, how they think about concepts, and there's also differences in what is hard for them: executive functioning, sensory differences, social communication differences. And so we're adapting CBT that's helpful for kids already in the general population to kids with autism. Next slide. So some of the things you want to think about are, CBT actually has been helpful and both CBT for anxiety and mental health conditions, in particular for anxiety. There is a lot of, trials that have been done, big trials, smaller trials, but they're small to medium effect sizes that show that CBT can be helpful for treating both core autism symptoms as well as these co-occurring mental health conditions. Next slide. So some of the unique things about autism that we want to think about is really they do have difficulties transferring skills from one place to another. So we got to figure out how do we address that. Then they have differences in motivation that can affect their engagement. So we got to think, how do we help them with their engagement? We also have a lot of information to show for a lot of them, visual-based learning is much stronger. So it's not just talking, but can I have visuals? Can I actually, help support them to remember some of these things? And then a lot of this is tied to their attention and executive functioning weaknesses. It is really hard for them just to retrieve a memory without any cues, and it's really hard for them to tell you about their experiences in an organized kind of a way. And so you want to support all that. Next slide. So here's lots of different ways to enhance CBT. For autism. The use of social stories or vignettes really helps them so they can kind of visually see, what this thing is about. There's an emphasis on therapist modeling and joining in children's practice of behaviors. The involvement of caregivers and other relevant family members is really important. You want to make sure somebody's there to help coach the kid to use those skills outside of the clinic setting. You want to incorporate children's special interests so they find the things that they're learning motivating. You want to use cues to support them. So giving them choices, giving them structure to remember or talk about their day, helping to be like, okay, was it this or that happened to you? First, tell me the first thing that happened, second thing, third thing. So you're kind of structuring them. The visuals also really help with this. You're using simplified concepts and language, and you're also trying to target some of those core autism challenges because those feed into those mental health conditions. And then you're thinking about a greater number of sessions or longer duration of sessions. And that can be hard to have longer duration of sessions. So you're probably looking at longer, more frequent sessions or longer time that they're in treatment. And then you're going to really want to emphasize practice of those skills, not only in the clinic, but at the home and places they need it, like at school. You want to make sure learning is hands-on and active. That's how you're engaging them. And then you want to really make learning explicit. You're connecting the dots. Hey, when you use this skill X, Y, and these other thing happens. Oh, look, it helps to improve your day. That is very hard for kids with autism, to connect the dots. And so you're making it very explicit for them. Next slide. Here are just the last two things about some randomized clinical trials for anxiety, as well as core features of autism. So one, for anxiety, there's a lot of information showing that CBT for anxiety and autism can be very helpful. The helpful thing I want you to take away is CBT used in a standard way can also be helpful. One study showed that when they use CBT, which is coping cats, which is a standard CBT manual that for typically developing kids, about 38% of kids had an improvement in their anxiety, which is awesome. But when you adapt CBT for autism, you're kind of seeing greater improvement and seeing more kids showing improvement. So that's the benefit of having adapted CBT. The other thing is that for some of the core features of CBT, this is an aspect that's being more and more researched, is basically parents and researchers were seeing that they were able to help improve social communication outcomes and core, challenges that parents were having related to autism. And they were seeing that CBT really helped kids address their core features. And that was more helpful than maybe like a more generic kind of group treatment that really wasn't focused on using CBT to address core skills, but kind of more like a supportive therapy. Next slide. So if there's only a couple takeaways you could take from this, really is if you can really make sure you're listening for and guiding your patients to really ask for treatments that involves active practice of skills. If your families are saying, we just go in and talk and I don't know what my kid's actually doing in therapy, that's a red flag that although it might be supportive, you're not going to see a lot of immediate effects, and that, there needs to be a more active element to treatment. There needs to be also parent involvement, especially for kids, where parents learn how to coach their kid, because any kid's really going to have challenges applying tools once they leave the clinic setting, but that's especially true for kids with autism. And then you really want to make sure that the treatment is personalized for the child rather than a general approach. Is the therapist including the child's interests? Are they including some visual supports as well? So I think that's it for my end. I think now we're going to welcome some questions.
Thank you so much, both Dr. Patrick and Dr. Lane, for the talk. This is so helpful for us to conceptualize comorbidities, diagnosis, medication, and therapy strategies. There are a few questions, great questions in Q&A, and also in chat. There's one that's from Dr. Vivian Bemusto about, can you go back to the previous slide about parenting scaffolding and speak a little bit more about that? I think it was probably the first 10 slides.
Yeah, so I'd say a lot of times in kids who have like adaptive functioning challenges, you may see parents providing a little extra support in their day-to-day activities, and it's very helpful to be kind of aware of those differences in terms of how the family is functioning when you're kind of assessing both like what is expected of the child in their day-to-day activities, and how those expectations may kind of interact with like our idea of what dysfunction is of a kid of a certain age.
Okay, thank you. The other questions is about medications. How would you start medication for autistic kiddos with comorbidities? Any specific tricks that you would use, or any specific guidelines that we can follow? And then also specifically, sometimes if the patient is taking more than one medications, such as SSRI and stimulant.
Yeah, so I think just kind of some general principles is, starting one thing at a time, and sometimes it can be really difficult to prioritize when there's multiple things going on, but trying to come to an agreement with the parent and get their buy-in on which one to start with. And it can be, I often like to kind of follow the parent's lead there, just so that I know that they're bought into the treatment. And I think you're going to follow the principles you use with other patients as well, checking family history of response to specific medications. I think particularly with kiddos with ASD, you may want to check in on, had they tried an SSRI or another medication before and had some side effects? Was there already like an SSRI trial with an activating response? That may make me a little cautious and kind of quicker to go over to a non-serotonergic agent. Or explore those options, and maybe a trigger to give us a call and discuss the case. And I think, and then just kind of going slow. Oftentimes, if I'm concerned about sensitivity to medications, I may plan a relatively closer follow-up. But with that, what I mentioned in mind also about being concerned about like underdosing for kids with ASD when we're starting really slow, is I may give parents kind of a two-step intervention between appointments, where I say, okay, we're going to start really slow on a medication, but as in 1 to 2 weeks, if everything's going fine and it's being tolerated, then we can kind of increase up to the typical starting dose, so that next time we meet, as long as there weren't any problems, we're kind of where we want to be in terms of making progress with treatment.
Thanks. The other question is for both Dr. Lane and Dr. Patrick. How do we screen for mood disorders in patients with autism? Is it sufficient to use PHQ-2 and GAT2 instead of PHQ-9, GAT7, or other tools?
Yeah, so I think I really like starting with I think a PHQ-9 remains a good tool to start with, though if I'm getting conflicting information in the appointment, either from parents or from the kiddo, I think it can be helpful, and this is true for any scale really, to review specific items, and kind of if particularly if I've heard something conflicting about an item in the appointment from either parents or the patient, to kind of dig into that a little bit more. I think I put this on a slide but didn't go into it verbally. But I think one thing that happens with kiddos with ASD, especially if rigidity is a big feature for them, is they may put extreme responses on scales of 0s or 3s, and that can certainly lead to kind of erroneous negatives or positives in certain situations. So kind of following up verbally can be really illuminating.
So perhaps starting with PHQ-9 and GET-7, and when there are clinical nuances, then definitely involve clinical interview and collateral information. This may be a question for Dr. Lane. If you see a middle school student who has difficulty with friends and suspected having autism, is it reasonable to have them complete the SRS-2? And if positive, then just refer to child development and then recommend social skills training. What would be the treatment planning?
Yeah. I think the use of like questionnaires or screenings, that's really what they are. They are just screenings, right? And so if you did use a screening, something became elevated, that's great. Then if you have information that the child is having difficulties with social interactions, I think it makes sense to refer them for social skills training. Any kid could get social skills training. You could even just have ADHD, right? And so it's not specific for autism. But I would also say too, not just to rely only on, questionnaires, especially for kids. They might not be the best informants, but, kind of really listening to the parents. What are they seeing is coming up? Sometimes they might have concerns, but it's not coming up on any of these screenings. And still, they give you verbal information about a concern. And so I would still refer them. And if there are concerns and they haven't been diagnosed, making sure that they're getting a diagnosis from, a psychologist or somebody who specializes in developmental types of evaluations.
Thank you. And there's another question about, is there any videos that can demonstrate what these modified CBD sessions look like for autism patients?
I will look for them and send them to you, to our team, so they could email it out. I do not know, so I will look though. That's a very good question.
Thank you. And this question is for Dr. Patrick. Is there a typical dosage for melatonin for autism patients?
Mm. Yeah, I use the kind of general same dosage guidelines of kind of like, starting as low as like 1 milligram up to 10 milligrams and kind of going slowly up that ladder.
Thank you, Dr. Patrick. And then finally, there's a question about if an adolescent with autism who has a mixed symptoms of comorbid ADHD and likely some OCD, but also seems to have only minimal improvement with methylphenidate, side effects including be more irritable, would you move to treating OCD first with the SSRI, or what else will be the treatment planning?
So I think that, that sounds like a very complex case. And I think, a situation where I think like a call and further discussion about case specifics would be really helpful. I think some questions that I would have up front are, what is kind of like driving the presenting problem or dysfunction in that patient. If it still seems to be predominantly ADHD symptoms, then I may explore other treatments for ADHD prior to moving on to treating OCD. If it's truly, and I think another thing to check in with would be the family and their kind of like appetite and motivation for treatment of each cluster of symptoms, which, because I think like the patient alliance and kind of the patient motivation for any treatment, including medications, can have a big impact on success and compliance.
Thank you. And we're at time. So thank you both so much again for bringing us this new webinar. Really important topic, very interesting. Apparently everyone's having good questions about it. There's one more participant that just raised their hand, but we're not able to unmute people. If you have any follow-up questions, please feel free to call CalMap. You can either call us at the phone number that I just posted on Q&A, or request a consult online on our website. Thank you all so much for attending today. Have a good week.
Bye,
See you.
thank you.
Bye-bye.